Right, esteemed members, good evening and a warm welcome to today's webinar. Just to confirm if you can hear me, kindly send a message on the chat and let us know which branch of PSK you're joining us from. Good evening, Sylvester, Benson, Chani, Hillary. Welcome. Thank you so much for confirming. Josephat. So we have members from Kilifi, North Rift, Isiolo, Kakamega, Kwale, Turkana, Lodwar, Siaya, Baringo, Eldoret, Mandera. Welcome. Thank you so much for confirming. Trans Nzoia, Machakos, Basa, Tana Athi, Kisumu, Kisii, Wajir. Thank you so much. I see everyone is here. So I'd like to just request if you can take a minute of your time, just go to the PPB portal and subscribe to this event. And you can use the keyword TPT and you should be able to find it easily. Well, for those who've joined, we are just subscribing to this event on the PPB portal. You can use the keyword TPT and you should be able to find it easily. And remember, we've actually just started the month where we are required to renew our licenses. And you're also required to to ensure that your points are at a minimum of 40. So if you haven't achieved that, ensure that you take advantage of the few events that we have coming up this month and December so that you have the minimum required points for you to renew your license. And for some of the events that we have not shared the CPDs, we have some that are going to be sent, so be on the lookout for that. Right, so I see we have a good number to start. Once again, welcome to today's webinar. And this is second part webinar. Initially in July, we had a webinar on the same topic, and this is more of like a continuation. And we're glad to be having MSH supporting this webinar. And it's in partnership with the National Tuberculosis, Leprosy, and Lung Disease Program with the Ministry of Health and Tamatisha TB. So today's webinar is on TPT Unlocked, and we'll be looking at navigating new shorter regimens through the pharmacist lens. And for today's webinar, we have Dr. Ernest Mbai, who's the Senior Deputy Director of Pharmaceutical Services under the National Tuberculosis, Leprosy, and Lung Disease Program. So once again, this is just an image reminder that you're required to subscribe to this event on the PPB portal. Remember that the sooner you subscribe, the sooner the CPD provider will be able to send the tokens to you. You can use the keyword TPT so that you're able to find it easily. And a few ground rules will be muted during the entire course of this session. So if you have any questions, kindly use the Q&A tab so that we can easily track the questions and they'll be responded to by the presenter at the end of the session. Remember, this session is being recorded and will be made available on the PSK YouTube page. So we'll be having the presentation by Dr. Ernest that will be starting. And then thereafter, we'll be having Dr. Cecilia Mwiva, who will be speaking on behalf of MSH. and then we'll have the question and answers. So I'd like to encourage you to have your questions on the Q&A tab, and in the end, we'll be having the presenter address them. So at this point, I'd like to welcome the presenter, Dr. Ernest Mbai, who is going to be taking us through this session. Dr. Ernest, if you can hear me, karibu.
Thank you so much, Dr. Ezra. Good evening, colleagues. Thank you again for lending me your ear. Let me quickly just put up my slides and then we will start. Confirm you can see my slides.
Yes, we can see.
Thank you. Thank you. So again, thank you so much for lending me your ear. This is, as Dr. Ezra has mentioned, this is a continuation of a series I started in the last webinar, where I gave you a full overview of TB. So I'm now zeroing on some of the specific aspects of TB. Today, I will be speaking specifically on TPT, that is TB preventive treatment. I will have other subsequent webinars where I'll focus on on other aspects of TB. So maybe the first question you would want to ask yourself, why are we focusing on TPT? Why are we talking about TPT? Why are we talking about giving medication to people who, in all sense of the word, are actually not sick? And for me to start, I'm going to take you back to one of my slides in my last presentation, where I gave you this slide on the natural history of TB infection, where I indicated that of the people who are exposed to TB, 10% of those will fall ill, and 90% will have TB infection, but they will have asymptomatic TB. Essentially, they will not develop any any signs of active TB, and they'll be non-infectious. But if you look at the numbers, that's 90% of the cases who have been infected with TB. Last webinar, we talked a bit about how to deal with the active cases, how to treat them, how to manage them. But you can see the bulk of the people have not yet been not addressed, and that is why we focus so much on TPT. So moving over to the burden of TPT, the WHO, according to the WHO, we have an estimate that a quarter of the world's population actually has a TB infection. That is, you have TB, but it's not, it's asymptomatic. And these people tend to become a reservoir for emerging TB, because in as much as I remember in my previous presentation, I mean the last webinar presentation, I mentioned one of the reasons why they do not exhibit active TB disease is because the immune system is up to task and is able to keep the TB in check. So the bacteria goes into dormancy. So essentially, you're not completely cured, but you do have the disease. So in cases of reduction in immunity, then you have an emerging. You end up having an emergence of active TB. So that 90% tend to form a big pool of people that can actually bring in new TB. Because as we put in steps, measures to try and control TB, to make sure that we are decreasing TB infection, to reduce number of new TB cases, then what is left are the ones that have the TB infection, and these ones with the changes in the immunity system, then they have emerging TB coming up. Unfortunately, as a country, Kenya, we do not know the extent of the people who have TB infection, who have TB that is asymptomatic. And that is another reason why we are focusing on TB prevention is so critical in public health. So why TPT? I've mentioned the reason, the burden that we have, the reasons why we expect to have why we would be having TPT emerging. So why do we have to focus so much on TPT? The first one is, as I've already mentioned, is to prevent progression of the TB from a TB infection to active disease. And this is by killing the dormant cells that are being held in check by the body's immune system. Of course, the other reason is to reduce morbidity, because the moment you have an emergence of TB, then of course, you're going to have TB disease, that active TB disease that with its attendant morbidities that end up keeping you off, reducing your man work hours and all. Then the other reason why we focus so much on TPT, it also saves cost. One is you look at the cost of treating. You're using 4 antibiotics versus two antibiotics as a maximum 2 antibiotics that we normally use in TPT. I'll talk more about the regimens that I use. You remember from my last presentation on treatment, you usually have a minimum of 4 medicines, antibiotics for the DS, and of course, as you move to DRTB, the numbers increase. So that contributes to reducing the cost of the treatment. Just to put numbers, to treat TPT, one full regimen of TPT, the one that is used for adults a lot, we'll talk about this regimen a bit more. It's a combination of piperacillin and isoniazid, costs about $12. To treat a TB patient with a TB patient pack, that costs about $35. You can see the difference. And studies from the WHO have shown that it offers a savings of $4 to $39 for every single dollar invested. So other than the medicines, of course, there are the other attendant costs that come in with when somebody has progressed to active TB disease. There's the lab, the diagnostics that have to be done. There's the loss of man hours when that patient has to be isolated. So all those costs add up. So when you just focus on preventing the TB, then you make all these considerable savings, because then you don't have to focus so much on the treatment. And then the question also you ask, what are the chances of, since you're using, I remember in my last presentation, I talked about having a minimum of four antibiotics to treat so that you minimize the emergence of resistance. In this case, for TPT, the maximum number of drugs we have is usually 2. And we actually have quite a number of the regimens recommended actually monotherapies. Why? Because in this case, the immune system is holding the mycobacterium in check. So the mycobacterium has gone into dormancy. It is easier to kill. It is not actively replicating. So you have minimal risk of resistance when you're using 1 or 2 drugs to cure the TPT. The TB infection. So quickly, let's talk about some of the definitions. The TB infection. Previously, it used to be called latent TB infection. And this is a state where you have TB, mycobacterium, but you're asymptomatic. So it is your immune system is keeping the mycobacterium in check, and therefore you are not having active disease and there are no symptoms. Then there's TB disease. Now, this is where the TB, the mycobacterium has overwhelmed your immune system, and you actually have active TB with the attendant symptoms of TB that we all know: the loss of weight, the night sweat, the chest pain, the persistent coughing, and all. Then there's TB preventive treatment. This is treatment offered to people who are at risk of TB disease. And when I say people at risk, that does not necessarily mean people who already have TB infection, but also people who we may not know whether they have TB infection or not, but they are at risk. We'll talk more. I think in the last my last presentation, I talked about the people at risk, but I will also talk a bit more. I will also revisit. I will remind you the people at risk. So all those are the ones who are going to be put on TB preventive treatment. Then who's an index case? The index case is the person who has been identified, regardless of age, who has been identified to have TB in a specific household or in a setting where they are likely to infect other people. And contacts. Now, these are the people who have come close to that index case, whether it's in the household, whether it's in a social setting, like a workplace, like a learning institution, or those people who've actually spent more than one night in an enclosed environment with the index case. That is a person who has TB. So all those are considered as contacts and who are at risk of getting TB from the index case. So let's move over now to the treatment, where as pharmacists, where our focus mainly is. So who do we treat? Who are we going to focus on? Who are we going to treat for? Who are we going to put on TB preventive treatment? This we covered in the last webinar, but the first group of, actually they're too broad. They're divided into 2 broad classes. those individuals who have reduced immunity. So these are like people living with HIV, whether they're children, adults, or adults or adolescents. Then also people on immunosuppressants or undergoing dialysis or on organ transplant or any medical condition that lowers their immunity. Then the other broader group are individuals who've been exposed either directly or at a higher risk of being exposed to TB, to a TB index case, to a patient, to a client with TB. So these are number one, healthcare workers, and not just healthcare workers, the other staff working within the healthcare setting. So including ourselves, the doctors, the clinicians, even the subordinate staff that clean or serve tea or whatever it is that they do in the hospitals. Those ones fall under a higher risk because you are more, you have constant contact with patients, some who may have TB and not know, and some who actually know have TB. And then, of course, the other group at a higher risk of getting TB are prisoners and staff working in prisons. You remember TB is spread through droplets. So if you live in an enclosed environment for long periods, then you're more likely to get TB. And then, of course, the final at-risk group are the contacts. Anybody who's come into contact with a patient who's been confirmed. And when we say confirmed to have TB, it's not just confirmed, but bacteriologically confirmed, where we've actually tested the blood and found that the mycobacterium is present in that person. So in the sputum, sorry, not the blood, in the sputum, and to have TB. So all those contacts, that means you're at a higher risk of getting TB. So those are the classes of group of people who we put under TPT, under TB preventive treatment. So before we initiate TPT, there are several considerations that we have to take into consideration. So the first one, we've already identified. First, we identify those risk groups that I've just taken you through. So if you're among that risk group, the next step is to confirm that you do not have active TB disease, because the last thing you want to do is to do single or mono to give you suboptimal regimen to treat your TB disease when we think we are treating your TB infection. So we have to rule out TB. Then given the medications we are using tend to be toxic, especially to the liver, especially isoniazid, we also have to rule out signs of liver disease, any signs of hepatotoxicity, because we do not want to make the situation worse in the process of trying to protect you from TB, because we may protect you from TB but cause liver failure. So we also have to make sure that we have to make sure that we rule that out. So then the other is access for comorbidities, because comorbidities also increase the risk or actually can be a contraindication from taking TPT. And then also check that you're not taking any active substance abuse or alcohol, because these also have an interaction with the TPT medications. And of course, you also have to access for nutrition, because you have to make sure you're not malnourished. As we'll see in subsequent dosing charts, which is weight-based, then you have to be sure about your weight, the weight that you have. Then moving over to what the regimens that we use, they are divided into three broad categories. We have the isoniazid prevention, isoniazid, that is given for 6 to 9 months. This has been the mainstay and has actually been used for quite a while. Then we have the newer shorter regimen. The first one is rifamycin-based shorter regimens that are given from 1 to 3 months. And quite new is also TPT now for our MDR-RR TB patients. And right now focusing on levofloxacin, but we also use isoniazid for the isoniazid susceptible RR contact patients. Polydrug contacts who are not MDR-RR. We'll talk a bit more on that. So those are the three broad classes of TPT that we give, starting with the isoniazid IPT, isoniazid preventive treatment. So as I mentioned, this has been the mainstay for quite a long time, until recently when we started shifting to the rifamycin based ones, because they tend to have a shorter duration. These ones were used and are used as safely used for all adults, children, pregnant women, whether you're HIV, regardless of your HIV status. And multiple studies over the years have shown that isoniazid is quite effective at preventing TB disease. So in one case we saw it's actually a study in 2009 that did a systematic review of 12 random clinical trials, was able to demonstrate that isoniazid prevented the risk of TB by 33% in PLHIVs that were in those 12 studies. So in as much as you're moving towards rifamycin-based regimens, it is still used. Isoniazid is still used for those cases where these rifamycin-based regimens are not indicated. One disadvantage of isoniazid is the long duration of treatment. So this leads to low completion rates. Some studies have shown actually up to between 50 and 70% completion rates. Then, of course, there are also logistical challenges where you have 6 to 9 months regimen, and you're having a patient going to the hospital every month to take their medication. That poses a significant challenge to that patient, especially depending on their socioeconomic status. Then, of course, because of the increased duration, there's an increased risk of adverse events. So the longer you take, the more likely you have to get the adverse events due to isoniazid, specifically hepatotoxicity and peripheral neuropathy. And then, of course, there's increased risk of drug-to-drug interaction. You're taking that medication for so long, and some of these patients tend to be also on other medications. So the longer you're using concomitant, when you're concomitant using these medicines with others, the more likely you have to have, more likely you're going to have drug-to-drug interactions. So that is where there's a shift from the longer TPT, IPT, that is isoniazid preventive therapy, to the newer 3-month, to the newer 1 to 3 month rifamycin-based TPT. So the ones that are in use right now, currently, we have the mainstay, which is a combination of isoniazid and rifampicin. This is usually taken for 3 months and it's taken once weekly. So you can compare to the isoniazid that is taken for 6 to 9 months and it is taken daily. That's a significant reduction in pill burden. The other regimen that is in use is isoniazid rifampicin. This is used for 1 month and it is used daily. Another regimen that is used for TPT is isoniazid rifampicin. This is used for 3 months, just like the 3HP, that is isoniazid rifampicin, but it is a once daily regimen. And then we have the 4 months of rifampicin, taken again once daily. I will give specifications on when it is used in the next slides. So focusing on these rifamycin-based regimens, I've already talked about the duration and the frequency. So you look at the dosing. If you look at the dosing, then for 3HP, only taking 12 doses. For rifampicin isoniazid, you're taking 84 doses, and rifampicin alone, you're taking 120 doses, and the once daily, for 1 month for isoniazid rifampicin, you're taking 28 doses. This is compared to the 182 doses of isoniazid you're taking. So there's a significant decrease in the dosing that you're taking. In terms of cost, the 3HP regimen, that is isoniazid rifampicin, is cheaper than the isoniazid and than the isoniazid rifampicin. And in terms of utilization or indications in children, and this is a new indication specifically for 3HP, and this is one of the reasons why I'm having this webinar with you as pharmacists. So previously, isoniazid rifampicin regimen was only indicated for adolescents and adults above 15 years and adults. But additional studies have shown that rifampicin isoniazid is actually can be safely used for all ages. So this is our new a new change in our TPT strategy, that rifampicin can be used for all ages, from infancy all the way. For isoniazid rifampicin, same as rifampicin, isoniazid rifampicin, this can also be used for all ages, but currently we just use for pediatrics, because adults, we were already utilizing the rifampicin isoniazid regimen. For the months of rifampicin. This again is indicated for all ages, and though we do not have a formulation, a child-friendly formulation. So in essence, it's actually utilized only for children, for children and adults, children above 25 kgs and adults. So essentially adolescents and adults for the 4 months of rifampicin. Then the 1 month of isoniazid rifampicin, this is used for, it's only indicated for those aged 13 years and above. So going over into the how safe these rifamycin regimens are in pregnancy. For isoniazid rifampicin, the 3-HP regimen, its safety in pregnancy is not known. In essence, not that it is known to be unsafe, but we do not have adequate data. There's no data to support this, but we do have some trials that are ongoing that will hopefully in the next 1 to 3 years will actually give us data on whether it is safe or not. And there's a likelihood that we may probably proceed on into using this regimen also in pregnant and lactating women. For isoniazid rifampicin, this can be used in pregnancy. It is safe to use, and as we are all aware, it's already utilized in the RHZD regimen for treatment. So in essence, it's actually safe in pregnant women. Then the 4 months of rifampicin, again, we can extrapolate from the RHZD, but there's no data available on its efficacy, but you can extrapolate that it may be safe. Then for 1 month of isoniazid rifampicin, just like the 3-HP, the 3 months from isoniazid rifampicin, you do not have adequate data. In terms of interactions with ARVs, antiretroviral therapy, we do know rifampicin or rifamycin-based TB medicines are potent inducers of cytochrome P450. So they have been known to reduce the drug levels of our ARTs. So in essence, it's actually 3-HP itself is contraindicated for all PIs, nevirapine, doravirine, and etravirine, and the TAF, that is tenofovir, alafenamide. But for 3-HP, it has been shown that it can be used concomitantly with TDF, that is the tenofovir disoproxil fumarate, efavirenz, DTG, and tergravir. So this, in as much as it is contraindicated in some, it can actually be used in the mainstay ART regimens. Same applies to the 3 months of isoniazid rifampicin. Again, same contraindications and same recommendations for use. Though in terms of for the DTG raltegravir, for DTG specifically, here it is recommended that you adjust the dose, because since this isoniazid rifampicin is a daily dose versus the monthly dose for the weekly dose for the 3-HP, it is recommended for if you're using the 3HR, 3-isoniazid rifampicin, then you make some adjustments for DTG, increase the DTG dosage. So the other, for the 4 months of rifampicin and 1 month of isoniazid rifampicin is the same. The recommendations are the same because essentially the same molecules. Moving over to toxicity, very similar. So we have hypersensitivity reactions, you have skin reactions, we have GI reactions, and we also have discoloration of fluids. Mainly, either you have red or orange discoloration of the fluids, and then we have, to a lesser degree, we have case indications of hepatotoxicity, and this, given they are similar classes of drugs. So these adverse events are cross-cutting through the four, other than the peripheral neuropathy that may be indicated for in the isoniazid-based regimens. That is the 3-HP, 3HR, and the 1-HP, but not in the 4 months of rifampicin. So what are the advantages? What advantages do these rifamycin-based TPT regimens offer over the traditional IPT? So one is they have similar preventive efficacies to the isoniazid, and given that most of them, other than rifampicin, has isoniazid, that is actually expected. That is not a surprise. That should not be a surprise. More importantly, they are offered over shorter duration, either all 3 months or 1 month, 1 to 3 months. So either weekly or daily for the rifampicin isoniazid regimen. So this leads to better adherence, of course, leads to fewer adverse events because you're taking the drug for a shorter period. Again, reduces risk of drug-to-drug interactions. And in some cases where it's been shown that actually the drug-drug interactions are not as severe. And then, of course, it reduces the cost of the regimen. You're taking it for a shorter time, of course. So that means you're utilizing fewer of the drugs. So going over to the country, what are our recommendations? What do we recommend as our TPT regimens? I already alluded to this. The mainstay right now for the program, the main recommendation is 3 months of weekly dosing of isoniazid, rifampicin. Previously, the guideline was only for adults and adolescents, but now this has been extended to all children of all ages, both HIV negative and HIV positive. The other recommended regimen, it is here because currently we are still utilizing it. That is the 3 months of rifampicin isoniazid, the daily dosing. It is here because we are transitioning from the 3 months of rifampicin isoniazid to the 3 months of isoniazid rifampicin specifically for children come next year. So the guidelines have been revised, and we're in the process of starting. We are in the process of doing sensitizations of the healthcare workers. So this webinar is also forming part of, and I took advantage of this webinar to sneak this into sensitizing you, the pharmacists. So we will be starting this for the pediatrics. We will be starting this early next year, either in February or March. So communication will come to you. But you will see in my next slides when it comes to dosing, some of my subsequent slides when it comes to dosing, where as pharmacists, our role will have to come in. Because unlike the adult rifampicin isoniazid regimen, where we have a fixed dose combination. For the pediatrics, we do not have a fixed dose combination. We will have to be taking tablets of isoniazid and then combining tablets of isoniazid. Both are dispersible, but then working out the dosing, because it's a weight-based, we will actually play a big role there. Then, of course, the mainstay remains our 6 months of isoniazid. This is for those patients who are contraindicated for our rifamycin-based regimens, including our pregnant and lactating women. Our hope is the studies that are ongoing will also move our pregnant and lactating to the 3HP group, because that will simplify the monitoring and management of TPT. So now that we've dealt with DS, that is drug-sensitive TPT, a question has always raised. So yes, you have a lot of regimens for TPT for our drug-sensitive. What about our drug-resistant patients? What about our drug-resistant contacts? And given that drug-resistant TB offers much more, is actually a bigger issue, a bigger public health risk. Whereas in as much as we have fewer numbers, we would rather have nobody transmitting our drug-resistant TPT. So what steps we have moved over? We have actually started having regimens for TPT. Considerations towards determining TPT regimen is the duration. So in addition to the risk factors that I mentioned earlier, immunosuppressed, those ones at a higher risk of contacts, and those ones who've had contact with TB patients. Additional considerations for TPT for DRTB is the duration and intensity of exposure with the close contact, the resistance pattern of the index case, because not all not all drug resistance TB will have a regimen available. So we have to be sure about the resistant pattern. And of course, just like with the DSTB TPT, TB disease must be excluded. And more importantly, we exclude the TB disease, and then we are very sure about the resistance pattern of the patient so that we give the right TPT, and also we do not make the situation worse because we do not want to give a drug that is that the patient that the index case is already resistant to as TPT, because then we'll actually be we're making the situation worse and not helping the contacts. So what do we use? So starting with the most common resistance pattern that we have, that is our MDR-RR. If you remember from my last webinar, MDR-RR, these are DRTB patients who are resistant to rifampicin or to rifampicin and isoniazid. So any contact of that patient. And for that resistant pattern, that has been demonstrated that they are also fluoroquinolone sensitive. Essentially, yes, they are resistant to isoniazid and rifampicin, but the strain, the mycobacterium is sensitive to fluoroquinolones. Then those patients, the contacts of those index cases can be put on 6 months of levofloxacin. These are daily dosing regimen. Now, for contacts of all other cases of monoresistant TB other than the rifampicin, that is rifampicin RR and MDR-RR. What do I mean? The patients who are resistant to pyrazinamide, resistant to ethambutol, then the contacts of those index cases can be put on 6 months of isoniazid because they're only resistant to ethambutol or pyrazinamide, and it's been demonstrated that they are sensitive to isoniazid. Then the other regimen is for contacts of those who are isoniazid, to those index cases whose resistance pattern is resistant to isoniazid only. So they've been demonstrated to be that strain has been demonstrated to be susceptible to rifampicin. So this can be put on 4 months of rifampicin. So in terms of our guidance as a program, as it stands, what is rolling out directly as a guidance is the 6 months of levofloxacin for MDR-RR contacts. The 6 months of isoniazid and the 4 months of rifampicin, this is still under consideration, but there is a likelihood that early next year, we would be having additional communication that indicating that we can use the 6H and the 4R for the eligible populations. But right now, what is coming from the program and will be in a communication, if it has not already been received by the counties, is that for the contacts of index cases who have been demonstrated to have MDR-RR will be put in on 6 months of levofloxacin. Very quickly, I'll move over to TPT regimens and dosing. I will not focus so much on the regimens, but I will focus on where, as pharmacists, a role where we can play. So in terms of our dosing considerations, the WHO standardized the body weights. So in terms of all the regimens, we have standardized body weights that are body weight bands that are going to be used to dose the patients. You will see in my subsequent slides. Of course, for children, dosing has to be adjusted because they metabolize the drugs differently. And we also have to be very careful for since like for 3 months of isoniazid, rifampicin, I mentioned it can be used for all ages. That means even infants on the lower weight band can also be given. But you'll notice that if you have a child less than 3 kgs, that is most likely a malnourished infant. So we also have to be very careful when you're dosing, and that's where as pharmacists we can come in making proper adjustments to the dosing, even over and above the recommended dosing chart. You can actually make additional recommendations based on the weight that of the infants that you have, because again, we do not want to cause more harm in the process of trying to do good. Then what we should do, always avoid splitting non-dispersible tablets into fractions, unless it is less than half. And the recommendation right now from the WHO is you crush. If you do not have a child-friendly regimen that you're giving to a child, you can crush the tablet and then disperse it in 10 ml. It's 10 ml, but as a pharmacist, you know, it doesn't have to be 10 ml. What matters is the final dose that you're giving, that the final volume has the right dose, the right concentration of drug. And that again is another role we can play in. And you'll see in some of the dosing charts where we can actually come in and help the clinicians in giving the right dose. Because in some of our visits to the counties, that is one of the challenges we've observed the clinicians having in getting the right dose, especially for the lower weight bands that require more than just taking a tablet or counting a tablet, or you have to do some crushing or some dispersing and then dispensing a volume. And of course, you always have to take in factors that may increase the risk of drug toxicity. That is, if there's malnourishment, if there's a comorbidity, or if they're taking drugs that you know will be involved in drug-to-drug interaction. So you have to take that in consideration when you're advising on the dose to be taking. And finally, especially for isoniazid-based regimens, where you're combining our rifamycin with isoniazid, you always have to do pyridoxine supplementation to alleviate the peripheral neuropathy adverse events. So quickly to the dosing chart. I will not put this, as I said, this slide will be made available to you, and also it's also in our guideline. So what I want to focus on mainly on some of in the lower weight bands, like for the 6-month the IPT, you can see for infants between 4 and 8 kgs, what is recommended is you give 0.5 ml. So it is, you're supposed to take half a tablet, dissolve it in, disperse it, and then give 0.5 ml with a dispensing syringe. Sometimes there are challenges in doing this, and as a pharmacist, we can actually come in and show and indicate to the clinician the right way of doing this. Same thing again, if you look at our 3HP. 3HP, as I said, now is indicated for all children. You can see for the lower weight bands, what I was mentioning, when you have less than 3 months weighing between 3 and 6 kgs, you're supposed to give 0.6 of a tablet. Of course, that's not possible. So essentially what you're supposed to do is give 6 ml, dissolve your isoniazid tablet in 10 ml of water, and then give your 6 ml to give your to give the right dose. So again, as pharmacists, here we come in to actually advise on the right way of dispensing, number one, because as you can see for rifamycin, I mentioned that isoniazid rifampicin, we do not have a fixed dose combination, unlike the adult formulation where it's very easy. You have to take your volume of isoniazid and your volume of rifampicin, and then that is what you give to the patient. So you need to give proper guidance to the clinician to make sure that they disperse it correctly and then they dispense the right volume based on the recommended weight chart that that forms part of the communication that has been sent to the counties. So same thing applies to our levofloxacin. So we have the levofloxacin for the pediatric formulation, the dispersible formulation, but also given that you can see the WHO recommends that in case when you do not have the pediatric, the dispersible tablets, you can still use the levofloxacin at 250 milligrams. Can still be used for children. But this is not given as full tablet because a child of 3 months will get to take a tablet. So what they recommend is you crush, then you disperse in a volume of water, and then you dispense the indicated volume using a dispensing syringe. Again, this is where we can come in and advise the clinicians on how best to do this, Of course, our hope and our intention is not to have this. Our intention is always to have the levofloxacin dispersible tablets, but that should not preclude us from starting TPT if we do not have the level 100, but we have the 250, and that is where this part still remains part of the dosing chart, but it's not the ideal and it's not the recommended way to go about. It's just an alternative should you not be able to get the right regimen available to you. So concluding with what, as pharmacists, what role can we play? What role can we add? What value can we add in TPT? I think I've already alluded to some of them as I was talking. So as pharmacists, our role is evolving. We are moving away from being dispensers, from pill counters, to service providers, to caregivers. We tend to be the first point of first point of contact for most of these patients. They will come see you in your private clinic, in your private, pharmacy. So essentially you become a frontline health professional. So you're the first person to see this patient. And also we become more actively involved in the care management. We are not just telling you take this number of tablets for this number of days. We actually move over into giving them into medication therapy management, into adherence support, into training, into education, into patient education, so that by the time that client, that patient leaves your pharmacy, they go with full information and full trust that whatever you're giving them is actually going to help them. So one role I can think of is identification and referral. And this mainly for those colleagues for our colleagues in the private sector mainly, because the first point of call, as I mentioned in the previous slide, the first point of call when somebody gets a cough, they will come to the pharmacy. So as a pharmacist, I can help by identifying those individuals with a higher risk of TB infections. I can actually screen the patients. There are those screening questions that we usually give. You can actually do them at your pharmacy, aid in detecting and then referring. The ones that you see may have from your screening questions may likely have TB. Then instead of just giving them an antibiotic, you actually refer them to for formal diagnosis and maybe TPT initiation if they are contacts. Another role as pharmacist I see is in patient education and counseling. TPT is usually a big challenge for the program because here you're telling somebody to take medication where they think they are and they know, they feel well, they are not sick, they are not coughing, there's nothing. And then you're telling them, please take medicine, take this medicine for 6 months, take this medicine for 3 months. So you need to have very accurate, you need to give clear, concise information and to convince them the importance. So as a pharmacist, we can do that role in terms of explaining what TB infection is and why it is crucial for you to take that treatment. You can give specific information on the regimen that you're taking, including the dosing they have to take. And as I touched on the dosing, the right dosing and for the duration, for the right duration. Then, of course, giving them the right information on the expected adverse events that they're going to get so that they know and they do not use that as a reason not to take medications. So not only giving information, but also helping in managing those side effects. And then, of course, answering any questions that we may have, so that by the time they are leaving, they are very confident that the medicines you're giving them will actually help them. So another role is medications therapy management. So now we've already convinced them now how to make sure that they take the medicines. First, you make sure that it is safe. They're taking it in a safe and effective manner. So we will monitor, screen for drug-to-drug interaction, making sure that those patients who are taking concomitant medications that have been known to have interactions, that we actually take necessary steps to minimize the drug-to-drug interaction. The other is adverse events monitoring and management, much more important. You detect and then you manage. Proactive monitoring, like inactive drug safety monitoring and management. We already know that isoniazid tends to be hepatotoxic and more importantly, causes peripheral neuropathy. So you've already mentioned at the beginning under the counseling and training, you've already mentioned the expected side effects. Then you also play a role. You're in the front line in managing those adverse events in cases when they do occur. Then there's also regimen optimization. We collaborate with the clinicians to make sure that the right regimen, the right optimized regimen is given. As you've seen, especially for the lower weight bands for children, there's a lot of optimization that is going to be required. Just following the guidelines blindly could lead us into problems in identifying the right dosing and in reconstituting, dispersing those regimens in the right volume, giving the right dose, the right volume. That would be a very key role for us. Then the fourth role I'm thinking I envision us as pharmacists is in adherence and completion support. The patients can be taking their TPT medicine from the pharmacy. Why do they need to go to the hospital every day? The pharmacies tend to be closer to our clients and our contacts. So the dot can be done at the directly observed therapy can be done at the pharmacies, significantly improving adherence. Then follow-up, we can also be making follow-ups with support of the community health volunteers in ensuring that the right dosing the patients come in to take their dose at the right time and they get their refills at the right time. And then also, you can be involved in problem solving, finding out the issues that are affecting adherence. This can be in form of operational research. Find out why are patients not adhering in specific areas, in specific regions, specific zones. And that can also aid in giving information to the program to better optimize its TPT management. The fifth role, and the ones that we usually play, and for me, I feel it's a very small component of what as pharmacists we can do, and specifically not just in TPT, but in TB management in general. That is supply chain management. That is our work is to ensure that we make sure that the right regimen is available at the right time, in the right quantities, at the right cost. This is through proper quantification, through proper and timely ordering of the commodities and optimization of the logistics systems to make sure that the drugs are always available and you always have adequate stocks available in your various stores. This specifically for those of us who are in the public sector. So finally, in summary, I think as pharmacists, our role has moved from being a dispenser to being a caregiver. Our work is not just to push the pills, it's actually to make sure that the drugs are taken properly in the right form and they have minimal harm. And this will contribute not just to the TPT, but also actually to TB treatment in general. So some of the barriers so far that we have as pharmacists, I think the first one is lack of specialized TB training for pharmacists. We learn on the job, myself included. The other one is inconsistent or incomplete utilization of pharmacists in TB management. We tend to come in when we have issues with stocks, not at the beginning. We usually come in at the end of the process, while we should be involved from the beginning of the process. Then specific challenges, specifically for the private sector, if we want to integrate TB management, TPT management at the clinics, is time and workflow constraints in very busy pharmacies. It's going to be very hard for you to start screening a patient, a client when you are busy during your peak hours. And then also still related is the lack of integration with the public health reporting system. So you may be in a position to screen, but you have no way of integrating that into the available public reporting systems. But I still see opportunities. As pharmacists, we can come in to expand our TPT access to underserved populations. I mentioned that it might be easier to do DOT, for example, from a pharmacy instead of from the hospital. Might even actually end up reducing some stigma, because then if you're not going to the TB clinic to take your TPT medications, but you're going to the pharmacy and people expect you to go to the pharmacy to take medicines. Then the other one is to improve our public health, and can see opportunities where we can improve our public health efficiency by leveraging on the available pharmacy infrastructure, both in the public and in the private sector. We have a lot of expertise that can actually play a more direct role, a more frontline role in TPT management. Then we see areas of opportunity of strengthening our collaborative practices between us as pharmacists with the clinicians who are dispensing. Then I see significant opportunities in research. We can mention about the active drug safety monitoring and management. These are just examples. TPT commodity utilization trends. Why are specific areas, specific counties, specific sub-counties having higher TPT utilizations compared to others? TPT adherence attitudes. I've seen studies where I think it was in South Africa, about where people would rather take more smaller pills than one larger pill. So things like that. These are areas of research that as pharmacists, we can actually come in and actually improve the wealth of knowledge on TB management. with that, I say thank you. Thank you so much. And I am open now to any questions.
Right. Thank you. Thank you so much, Dr. Ambai, for that insightful presentation. And I think I want to believe our members have been able to learn a couple of things there. So just before we move into the Q&A, I'd like to welcome Dr. Cecilia, who's going to be speaking on behalf of the Management Sciences for Health, MSH. And then we get into the Q&A. So I'd like to encourage you all, if you can, if you have any questions, feel free to type it in the Q&A chat box. And then after this, we'll be having them addressed. Dr. Cecilia, karibu.
Thank you, Dr. Munyakin. Hello, everybody. I hope you have learned a lot today from Dr. Mbai's presentation, as much as I did. There's really, every time you attend one of these webinars, you just realize there's just so much more to learn and so much more, so many other ways in which pharmacists can help patients, whether they are suffering from TB or any other condition. On behalf of my colleague, Dr. Mukoko, and I of MSH, we would like to thank you for attending today's webinar. MSH is a subrecipient of the Tamatisha TB program, which is working with the National TB Program, selected counties, and other stakeholders to strengthen Kenya's health system capacity to achieve sustainable and quality TB control. MSH's focus in that program has been on supporting the TB program and counties to strengthen the management of TB program health commodities, but also their safe use. This webinar is a second one which is being held in collaboration with PSK and the National TB Program to enhance health worker knowledge on priority TB health commodity management issues. In the first webinar, which was held back in July, Dr. Mbai took us through the pharmaceutical management of TB in a very broad area, but today now he focused on TB prevention. MSH is very proud of the close collaboration and partnership that we have had with the TB program, with PSK, as well as with the counties and other stakeholders that we have worked with. It is our hope that the TB program will continue to collaborate with PSK to undertake more webinars to discuss more about how pharmacists can contribute to management of other priority issues in TB prevention, care, and treatment, but also, just like Dr. Mbai has said, also in research. How can we contribute more to the pool of knowledge? Thank you once again for participating in this webinar, and back to you, Dr. Munyakin. Over.
Right. Thank you. Thank you so much, Dr. Cecilia, and also Dr. Mukoko. Thank you for the support that you've also given us to have this webinar happen. So we're going to move directly to the Q&A. So if you have any questions, ensure that you just list them on the Q&A tab, and then we'll have them addressed. So we'll start with the first question, which is from Dr. Joseph Mwangi, who's asking, what informs the TPT regimen choice? So maybe Dr. Mbai, you can clarify on that.
Okay, so what informs the TPT regimens actually is we get this from the WHO. The WHO gives a regular guidance, so they have a team of experts that usually looks at current and existing research and the data, what that research, the information that research gives. So, and then from there, they extract the data and give recommendations based on the recommendation and the findings of the research. So an example is the 3HP that I mentioned that now we are going to start using in children from next year. Before, when previously we were not. There are two studies that were actually carried out. And from the data from those two studies, it was shown that actually 3HP can be safely utilized in children of all ages. And that is why they gave that guidance. So in essence, yes, all the guidance comes from the WHO based on existing research, on existing ongoing research.
All right, thank you. There's a question from Dr. Beatrice, who's asking, is there a risk of developing resistance to levofloxacin and cross-resistance that follows if levofloxacin is rolled out for drug-resistant TB prophylaxis, therefore limiting fluoroquinolone use for the DRTB treatment?
Okay, so from research carried out by the WHO, I mean, not by the WHO, but rather from research carried out and reviewed by the WHO, it has shown that there is minimal risk, and not just for levofloxacin. The same applies to isoniazid, where that was one of the bigger worries when we started isoniazid preventive therapy, that we are giving monotherapy, then we will more likely increase resistance, but that was never the case. What matters, what is actually of significance, is rolling out TB disease in the contact that you're giving. Because as long as you roll out the TB disease and you're sure you've confirmed, not clinically, but through lab testing, the resistance pattern. So if you've confirmed, in this case, levofloxacin, if you've confirmed first the resistance pattern that it's a MDR-RR, and we've confirmed that that strain is susceptible to a fluoroquinolone, then that means that the risk of bringing in resistance level is very, very low, minimal, actually. And then from there, of course, utilizing our existing systems of treatment, where we are having a DOT, direct observed therapy, that our existing adherence measures that we've taken in place. And we ensure that adherence is maintained, that that patient takes the level for 6 months. Then in essence, there's a very low risk of developing resistance or increasing resistance to levofloxacin, if that is followed. And as I say, you can actually use the case of isoniazid. You use isoniazid for very long, and you've not actually not been, the resistance that was expected did not come. As long as you do the initial rolling out properly, then that stops being an issue. Thank you.
Right. Thank you for that. The other question is by Richard Wangai, who's asking, do we need to adjust the dose of DTG when using IHP?
Sorry. So when you're using, I imagine you said whether you need to adjust the dosing for DTG if you're using 3HP. If that is a question, no, you do not. First, because it's a weekly dose, and studies have indicated that in as much as, yes, the 3HP, the rifampicin component of the regimen actually does lower DTG levels, but not to a clinically significant level. It reduces it to maybe by around, I think, 70 to 80%. But this has been shown. Studies have shown that this lowering still gives adequate concentration of DTG in blood to still give adequate viral suppression. So no, for 3HP regimens, we do not need to make adjustments for when you're concomitantly giving with the DTG-based ART regimen.
All right, thank you for that. There's Dr. Yusuf who's asking if we need to reconstitute levofloxacin tabs for PIDs. Is it recommended that it is done on a daily basis, or for how long? I'm worried about the stability.
So if on the unlikely event that you have to use the adult, the 250 milligram, it's a one-off. Just like you can't keep. You're supposed to take that one tablet, crash, give the right volume, then discard the rest. Because we do not have any adequate studies that will show that shows the stability. The studies that we have show that that there is a comparable bioavailability of the levofloxacin compared to a dispersible tablet. And if you look, when you do get these dosing charts, if you look close, you'll actually find that the tablet dosage for the 250 is slightly higher than the dispersible tablet, because studies have shown that it's about 70 to 80% bioavailability if you're using the non-dispersible tablet compared to the dispersible tablet. The non-dispersible tablet has a 70 to 80% bioavailability. That way, you need a higher dose to get the same concentration. So you can only crash and use for that one time. You cannot store and then use that in the fridge and then use it for the next days treatment regimen. No, it's just that one tablet, crash, use, and discard the whatever is left. Thank you.
Right, thank you for that. Dr. Robert is asking, can pyridoxine decrease the mechanism of action of PTP? And if yes, how?
I did not get there. It reduces the mechanism of action of
PTP.
PTP.
Yes.
TPT or PTP?
I think there could be an error with
TPT.
the question.
So if it's TPT,
no.
no.
TPT,
So
yeah.
TPT, so no. Pyridoxine. What pyridoxine does? Pyridoxine is it's used prophylaxically to prevent the development of peripheral neuropathy. Peripheral neuropathy, in this case, is caused due to isoniazid, which isoniazid is an analog of the vitamin B6. What it does, it depletes the vitamin B6 in the body. So you're giving pyridoxine to replenish what the isoniazid component of your TPT regimen has actually depleted. So no, pyridoxine will not have any effect on the efficacy of your TPT regimen. Thank you.
Right, thank you. And so there's Dr. Flora who's saying for kidney transplant patients, they currently give isoniazid 300 mg once daily for 9 months. And she's asking, what is the current recommendation for this cohort, if there's any update on that?
So with regard to that, it was one of the regimens, though it's not yet. It has not yet reached the guidance. I mean the a recommendation. It's not yet a recommendation from the program, but I know that what for organ transplants, what is used is the 1 month of rifampicin, rifampicin isoniazid. But it is not yet a guidance, but it is something that as a program we are still in discussions with, because we understand the 9 month of 6HS is not tenable. So it's something that's also is under discussion and probably may change. A guidance may come in the future, but yet there's no other additional guidance so far at the moment with regard to that. Thank you.
All right. The other question is actually it's a comment that Dr. Solomon is requesting for on the toxicity of aminoglycoside injectables in children, and does the benefit of levofloxacin outweigh the risks associated with the pediatric population?
The first part is we rarely use aminoglycoside injections these days. We use amikacin, yes, but that is for our XDR patients. And rarely do we do not use, so it's not a significant issue in terms of adverse events anymore. Because yes, previously we used to have a lot of issues of ototoxicity and people actually having complete hearing loss because of the use of the aminoglycoside injectables. But we moved from that a while back. So we are, even for our DRTB patients, we moved to injection-free regimens that do not use amikacin. In terms of the cost-benefit analysis, it's actually more. We look at when you're dealing with children tend to be highly susceptible towards getting TB because of the nature, the bacillary nature of their TB. So on infection, they are more likely to get TB and they're more likely to get a severe form of TB. So I'd rather prevent the TB. So when you look at the cost, the benefit, risk-benefit analysis, it is safer to prevent the TB from a child contact than not giving that levofloxacin. Because you look at this, when you're looking at a child, especially an infant, and if the contact is a mother, so that means they're more likely to get exposed because you can't even keep a distance. You can't isolate the child. They have to be in contact with the index case, and they probably have been in contact with the index case. So I'd rather prevent development of TB in such a case. Thank you.
Right, thank you for that. So there's there's Dr. Patel who's saying, I work in HIV TB programs in several countries as a supply chain specialist. And one of the major findings in many countries is the wastage of anti-TB medicines, largely the TPT treatments, which highlights poor uptake of the treatments. What strategies are adopted to ensure uptake in accordance with the forecasts and targets set by the program? And an additional comment is for pharmacists to monitor stocks to mitigate expiries. And he also says a closer collaboration between the TB program and the pharmacists could improve program delivery.
Thank you,
So,
Dr. Patel. I can agree. I agree with you wholesomely. That is a challenge we are also experiencing here because of the very low TPT uptake. Our right now, from last year, our TPT uptake was 38% of our targets. So that tells you we are doing very poorly in terms of our TPT uptake. And some of the culprits actually, we are in this meeting. We are healthcare workers here who've not taken TPT. I know quite a number of us haven't. So some of the culprits are the healthcare workers. And of course, there's that other challenge of trying to convince somebody that they are not sick, that they should take medicine. So we've taken measures in place. One is we've dealt, there's a lot of patient education that is going on, client counseling, client information education that is going on to ensure that there's an increase TPT uptake. Then there's also close engagement with the counties, with the TB coordinators, both at the county and sub-county level, and also including the pharmacists, and those to increase TPT uptake amongst the contacts of the TB patients. So we have a very good reporting system that reports our TB index cases, and it's just a matter of expanding that to actually now follow up on the contacts. The other thing, and we are riding on this, our community healthcare workers, the community providers, the community workers, the community volunteers. I don't know the right name these days, it keeps changing. They do a lot of work in contact tracing, in following up the patients, and the index cases of the patients, and then bringing them to the clinic to start their TPT medications. The other thing is we also work on this percentage. When you're doing the quantification, because we do have an annual quantification, we monitor our quantified amounts versus the consumption. And where we notice our consumption does not match our quantification, we do reduce our quantification amounts by a percentage that will make sure that we minimize wastage. But wastage, unfortunately, is still there because of the low uptake. In terms of the closer collaboration, that one I think I agree, and it was one of the recommendations I mentioned, that the pharmacists have to have better collaboration with the clinicians. Thank you.
all right, thank you for that feedback. I see there was a question by Dr. Geoffrey, who asks, what do we need to ensure good uptake of TPT by the community? I think you've partially talked about it, the education that needs to be done, and also collaboration with the county. I don't know, do you have any other comment on that?
I think I addressed it in my previous answer.
Okay, thank you. There's Dr. Robert who says MDR is one of the problems we have in our health sector. While taking the TPT of isoniazid and any other anti-TB drugs, and unlucky enough you get infected with TB, will it be of any importance for future use and the benefits?
I don't think I got the question.
So I guess I think
completely.
from my understanding, it's considering now that we have the drug resistance, and if someone takes it just to protect themselves, and then it happens that they're unlucky, they get infected with TB. So, and maybe they require to take the same treatment. Considering we have the drug resistance, will it still be of benefit to them?
Okay, so now I get the question. So if you look at, let's use MDR, the MDR resistant pattern as an example. So for those patients, we indicate that they take levofloxacin. So the treatment regimen for MDR-RR is a regimen that contains 4 molecules. It contains bedaquiline, it contains pretomanid, it contains linezolid and moxifloxacin. So in case now, assuming that patient, the client, the contact, took levofloxacin, and they took for the 6 months, then unfortunately they ended up getting TB from another source. It doesn't have to be from the index case, because essentially by them taking the TPT, they've been protected. So they get from another source. As long as that source, that the pattern, the strain, the resistance strain is an MDR-RR, then they can still continue to utilize the regimen that I've just outlined, that is utilized for MDR-RR. So in essence, it does not preclude and it does not exclude them from utilizing the regimen. What happens is, should we find cross-resistance, should the strain they get, which is not as a result of the TPT regimen, by the way, but should they get a resistance strain that is also resistant then to fluoroquinolone, we do have an additional regimen that they can take. We can take the same regimen minus the moxifloxacin, and then they can take that for 9 months. So essentially, in essence, the TPT regimen that we are giving, the level does not in any way prevent them from taking the MDR regimen that's available, should they in the future be unfortunate enough to get infected with a resistant strain. And the same applies for the other regimens, because for the other regimens, because the recommended regimens do not form part of the treatment regimen for that resistant strain that the contacts are being given TPT medicines for. Thank you. I hope I was clear there.
Yes, that is clear. And I think there's one comment by one of the members who says many years ago, his cousin who was undergoing TB treatment at a public health facility went blind, and the reason was optic neuritis due to ethambutol. And at the time, he was still a pharmacy student. So he called the clinic, and the CEO managing the cousin had not linked the gradual loss of vision to the medicine that was given. But unfortunately, it was too late, and the vision loss was permanent. But the point he wanted to pass is ADR monitoring with a pharmacist at the center would have mitigated this. I think the other comment is Dr. Nyethe, who says TB is largely developing countries and poverty related. And Big Pharma might not be interested in R&D due to poor return on investment. What strategy do you think the WHO should take?
So I think with the first case, I agree with regard to the optic neuritis due to ethambutol. Our guidance is very clear that the moment you have, regardless of the grade, the moment you detect optic neuritis, you're supposed to stop the treatment and withdraw ethambutol completely, because we cannot take the risk of causing blindness. With regard to research, yes, it is true, Big Pharma are not that interested, but we do have, though now these days with what is happening with Trump, it's not very clear. But we do have a lot of research that is going on. We have the TB Alliance, for example. Like this new regimen for MDR-RR, the pretomanid component of it was actually manufactured. It's a very recent drug. It was just registered in I think 2022 in the US, and it was developed by the TB Alliance. So we still do have international institutions who recognize TB still is a challenge and who are actually still undertaking TB research. And also the Global Fund does fund some, of course, not in terms of drug discovery, but also still funds research components, operational research. So all this work towards still ensuring that we do have commodities in the channel, because we do have a significant number of drugs that are actually in the research phase, quite a number. I can't remember the actual number. And I know they include both medicines and also vaccines that are actually in the pipeline and undergoing clinical trials at various phases of the clinical trials ongoing. So it's not completely, we're not completely lost. We still do have some research ongoing. And we already have the product of one such research.
Right. Thank you for clarifying that. I think we'll just take two more last questions and then we'll close. So there's a question by Dr. David Chege who says taking levofloxacin for a long period causes tendonitis and the likes. What is usually done to mitigate these side effects?
Thank you for that question. And that is one area now in one of my opportunities, advanced event monitoring, ADSM. That is one area we can actually focus because this is the first time. We are rolling it out for the first time. This one will actually be doing this for 6 months. So we can actually, that can become a research topic, Daktari, that you can actually use and give us data on what we can do on the extent, not what we can do, because we do know what we can do. Of course, we already have recommendations, but what the extent and the severity of the same. Because right now, studies, the research that has been presented shows that they can actually be used safely for that period, for the 6 months that we are that we are recommending. But then the research, they're not that they're not in terms of the numbers, they're not that significant. They're not that many. Just that they're adequate enough for the WHO to make that recommendation. Thank you.
Right. Thank you for that. I think we'll just have the last question. Where Dr. Lewis is just asking for a recap on the rationale behind redirecting 3RH to be used solely among the 15 years and under 15 that is coming next year, despite 3HP being indicated also in the same age group. So maybe you can just recap on that before we close.
Okay, thank you. So maybe I may not have been very clear on that. What I said is right now the recommendation is PHP for all ages, but we currently do not have the PHP pediatric stocks in country. So we'll continue using the PRH, the rifampicin isoniazid regimen, until we have the stocks in country. And that's why we say we come maybe February, March, we'll transition from the 3RH to the 3HP. So the 3RH is just there as we await the commodities. When we have the commodities, then we will start the 3HP. And then, Doc, before I finish, there was another question I saw about where a colleague was asking now that TAFLD is contraindicated in 3HP. What is the advice? The recommendation in this case, since now in this case, the HIV status presidents, so that they will continue taking the RT medicines, and then now they will utilize, excuse me, the isoniazid. We remember I said isoniazid is going to be utilized for those cases where rifamycin-based regimens are contraindicated. In this case, since it is contraindicated, then they will continue taking the 6 months of isoniazid. Thank you.
Right. Thank you for that. So I think I'll just allow you to give a parting shot. But as you give the parting shot, you can maybe also just mention how the division is supporting research and innovation. I see that's one of the questions that has been asked by one of the members, Dr. Lucas.
Thank you. First, I want to thank you for your attention and the very, very interesting questions that you've asked. I hope I've answered them adequately, but in case not, you can always reach directly to me and we can answer whatever is pending. In terms of the research, yes, for me, I'm very passionate about research, and it's something I've been pushing that as pharmacists, you need to be more into research specifically with TB, because there's a lot of research that is being done in TB, but only on the clinical side. There's still some opportunities for us. So in terms of what the program does, so the program, unfortunately, we do not have a direct funding for research, so we do not fund research, but we do have a research task force that is a component of the program. So it meets quarterly, and in that research task force, it has members of the TB program, and then stakeholders, research institutions like Cambridge. And the purpose of that is to ensure that all research, number one, is to ensure first all the researches that are being done with regard to TB, the program is aware, number one. And then number two, that those any findings, recommendations that come out of those is actually taken programmatically and utilized in improving our TB management. So yes, in terms of anybody who may be interested in research, just get in touch with the TP task force, make your presentation, make your proposal, the proposal you have, and then the program will facilitate. We may not be able to give you, we may not be able to get the funding, but we will facilitate in terms of maybe there's data you need require, there's additional support you require in terms of opening doors for TB in TB issues, then the program will provide that support for you. And of course, we will become part and parcel of the research so that we become involved in the research and we are aware and are able to take the recommendations and implementation, the recommendations, sorry, of the research. Thank you.
All right. Thank you so much, Dr. Mbaye, for that presentation, and also thank you for your time. I think that has been a very good session, and I've been able to learn a lot, and we definitely look forward to having more sessions. I'd also like to just thank Dr. Cecilia and Dr. Joseph. Thank you for the support. And we definitely look for more. We're looking forward to more sessions in the future. So at this point, we'll just have a few announcements, and then we'll be closing the session. So the first one is to just remind you, for those who joined late, if you've not subscribed to the event, ensure that you do so. Then I've seen some questions with regards to the PSK membership fees, and the amount is the usual 10,000. And remember, the renewal of the license started this November. It usually starts every 1st of November. So right now, you can now just take the opportunity and renew your license. And I think for those maybe who've been logging into their account on the PPB portal, there's been this notification that has been coming up, PSK subscription details not found. So you'll be required to update your PSK membership so that you are able to get cleared to continue with the renewal of your license. So if you have any issues, feel free to contact us, and that issue will be addressed. But otherwise, once you update your membership via our portal, it is an automated process, and you should be able to just renew your license automatically as soon as you update the membership. And with regards to CPD, remember we're about to close the year. And for those who've not gotten some CPDs, we have a couple of events that we are yet to send out the CPD points. So be on the lookout for that. Hopefully in the next 1 or 2 weeks, you should be able to get CPD points for those events. But meanwhile, I'd like to encourage you to keep subscribing, because it's dependent. For us to send the CPD points, it's dependent on you subscribing for those events. So ensure that you subscribe to those events so that you have the CPD points on time. So I think that's the last announcement we had. Once again, thank you so much for joining. See, Dr. Nafisa is asking about Helion event, the points. We are yet to share that, so we'll communicate once the points are ready. But for any event that we've had before October and you've not gotten the points, you can send an email to cpd@psk.or.ke so that you can be assisted by the CPD coordinator. So I'll just put the email on the chat, cpd@psk.or.ke. For all the issues that you have with regards to CPD, send an email to that email, and the CPD coordinator is going to assist you on that. So thank you so much. Thank you, everyone. Thank you, Dr. Ernest, Dr. Cecilia, Dr. Mukoko, and the entire membership. Thank you so much, and have a good evening.